So welcome everybody to today's GlowDerm webinar. We're absolutely thrilled for you to be here. Today we've got an excellent presentation by Dr. Daniel Cataldo and his team. He is a distinguished specialist surgeon in reconstructive surgery, and he's our expert speaker today. So your meeting hosts today are myself, I'm Emily Vaughan. We've got Josh Cortiglia, Pauline Ogola and Bisha Salim. So we're the GlowDerm Trainee Committee, and GlowDerm are an international alliance for global health dermatology. We're GlowDerm, and we're part of the IFD, so the International Foundation for Dermatology. We promote knowledge equity by improving access to education for dermatology trainees around the world, and we aim to provide free educational events and opportunities and to build networks, meet other like-minded people across the world and collaborate ideas. So a little bit of housekeeping again. So during the webinar, your audio will be muted, your camera will be turned off for the duration of this webinar. The webinar will be recorded. If you have any questions or comments, please submit these via the chat function or the Q&A button, and Josh will collate these and go through these at the end. And so we'll present these to the speaker. We'll be sharing further information about the GlowDerm Trainee Committee in the chat function as well. So without further ado, I'd like to introduce Dr. Daniel Cataldo. And I will just stop sharing my screen now.
Hello, thank you. You can see, but now everything is disappear. Now, yes, you can see me. You can see me. Do you hear me?
We can hear you and we can see you.
Okay, thank you. I'm really sorry about my voice, but I got a cough, and in Italy, I'm in Milan. There are many people in this situation. I don't know if it was the vaccine or less, but we got some problem of voice. I got it. Hopefully, I will be able to talk for half an hour, 40 minutes, and then if there is any question to ask, with pleasure. I don't know if you got another idea. Can I start? Can I start? Can I go? So we talk about canker moris. Canker moris is a disease well known. It started in the 1500. There are the first authors to write about that. They just know children, they died in a couple of weeks, but they didn't study deeply the way of the infection, how they get the infection, and which start always in the gum. When it is the inferior lip, the lip is very thin, so the whole lip can be harmed, like a situation like this. They live in the desert area, so sub-Saharan area, which is in Niger, in border with Chad, and even in the north of Nigeria. When the drivers arrive in the desert area, the situation is this one, is what they found, the children in this situation. The point is, they arrive too late as they don't have any coins, neither to call us, to call the drivers. They arrive to the hospital in malnourished condition, as you can see. nobody brush their teeth, just 2% of the population brush their teeth. Is a problem of hygiene, you know, and the time they spend with us, we teach them to brush their teeth. Where the infection start is always in the gum. The country where we're going is Niger. So it's it's in Niger. We're going to perform the operation at Niamey, which is in the border, in the other side of the Chad. The patient, they arrive from the desert area from Zander, which is 800 kilometers from Chad. And the bacterium, they provoke this lesion in just 10 days. So microthrombosis, and the skin is in this situation. We didn't perform any operation, just a toilet like this one to eliminate necrotic tissues, you know. And when it is in the middle of the cheek, where the infection often is present, the scar, the necrotic tissue, they fall down without bleeding. So the drivers, when they arrive, they perform a bandaging around their face, not because they are afraid of bleeding, it's just to avoid the loss of material. And then when the skin is detached, the necrotic tissue fall down, the situation is this one. So it is a cone, so deep inside, you know, and without bleeding, and quite clean around. It's quite delimited. This is a situation after a patient after 6 months. The infection, as I said, starts always in the gum. And, you know, the infection is produced as they eat, they bite, lift, or anything they found on the ground. And they harm the gum and the bacteriums, which are many, but Fusobacterium is always present. Fusobacterium necrophorum, Fusobacterium nucleatum, then there are Prevoltella intermedia, Prevoltella meningogenica, Bacillium cereus, Corynebacterium pyogenes. And then when they arrive, when you see a situation like this, does mean at the start, the infection, it was 4 times bigger than that, as the skin is healing its own with a huge retraction. The infection is always in children. 98% of the patient, we believe it was just in children, but as always in medicine, there is the exception. This patient, an adult patient with HIV, under treatment with lower immunity defense, develop cancro mollis. They always live in the area we mentioned before. And the differential diagnosis is with something you see every now and again is, leishmaniasis, but is a differential diagnosis borderline, as the leishmaniasis is chronic, is low, and canker humoris is really speedy. It's really very, very fast. Another disease is Burkitt. Burkitt is the same belt, sub-Saharan area, is the same belt as canker humoris. So the most important point of the work we performed for many years at St. Louis Hospital in Paris, it was to study the evolution of the disease. Why those children, they die so quick? And we study, we took X-ray from each patient with the skull of 3 years old skull without premolars, and the drawing with the PowerPoint to better understand which tissue were harmed after the bacterium passed through the gum. So in a situation like this one, we perform a drawing to show where the infection starts. So in this case, the molars, the canine, and incisors are harmed in the superior maxillary, and in the inferior, almost quite the same, as you can see. But the most important thing is the path of the infection is always vertical. There is when the canine is infected, as it is quite close to the maxillary sinus, it is at least the mucosa is harmed, and the lateral wall of the nose is involved until to get point 0. Point 0 is the maxillary, the frontal sinus, as you can see. The communication between the frontal sinus and the maxillary sinus in children, as you know, is open about 18 months. The infection starts when they have 2-3 years old, 4 years old. So there is not bone, it's just cartilage. So the dura mater stuck against the posterior wall of the frontal sinus, and the mortality in this case is almost 100%. So, but there is the exception of the rule. In this case, the infection starts on the right side, and it doesn't follow the path as in the other patient. It went to the opposite side, and as you can see, the infection get the opposite eye lobe. So, and when the infection is in the inferior lip, it can completely destroy, and you got a drawing. And those drawing, at the start when we arrived, we got 150 patients to operate, and we choose between them. Some ones we avoid. We said we study for a month until the next mission before to organize and to see which kind of approach the tactical technique to perform. The idea it was to solve out the problem in one operation or two. It wasn't anymore the children who must be always ready to be reoperated. They must be introduced in their society in one or two operations, you know. And the first of all, we don't perform any operation. Patient like this one, the only thing you can do is just to clean with tepid water. You know, a good dermatologist can do it. So to clean a patient with tepid water until to get a clean situation around and to be ready to for theater room, you know. So exceptionally, there are some cases in order to accelerate the healing, we are obliged to remove bone like this one, the malar bone, and be ready in the next mission to be reconstructed. There is those classifications that allow today for the new generation that will come there to reconstruct children's. They got the idea how to cope with them. In this case, we perform a slender flap, which is the flap we use the most. So taking tissue from the superior lips and then coming with a lot of mucosa, as you can see here, to reconstruct the higher, to give more length to the inferior lip. You know, in this case, in one operation, this is the advantage of this flap, which we modify in many cases. In one operation, you can reintroduce the children in their society and they can drink. And so it's reconstruct not just the skin, but the mucosa and the muscle. So it was like this and become like this in just one operating time. And often they drawing themselves. So in this case, it's quite the same, but we need much more tissue to reconstruct. And for that, we bring many from the opposite cheek and the superior lip, but it's always with a slender flap, you know, and she drawing herself. This is the drawing we performed to show you the kind of the technique. And in this case, we need to modify in a way the normal slender flap is not enough to reconstruct that. We need much more tissue as the lesion is huge. And so this is the result in one operation. So another flap we use is a converse. The converse is an old flap we use to reconstruct the nose. When it's quite easily, the nose is completely destroyed by this disease. The skin and the mucosa. And the first thing to do is to reconstruct mucosa. The infection in those cases is always the incisors, and in this case, obviously the canine, the right one, And this is the time of the reconstruction with mucosa. You know, the mucosa with a flap which is made just to do and to put the patient in this condition to think for the next mission to reconstruct. The nose, as you will see, is always reconstructed with a forehead flap. So in this case, is in one operating time with the forehead flap and with the river to give, you know, the river to give is the 7 rib in this case to, as a beam. In one operation become like this. And as you can see, the color match is become then in a few months the same. And in the forehead, there is any skin graft. If you put a skin graft there, you will see always. Like this is disappear completely. So we will see in the next patient the way to avoid any skin graft. So in this case, we modulate the superior lip, we roll the skin of the nose, the skin of the nose then is unrolled after a couple of months at least, and with the rib as a beam and sliding the flap, the forehead flap, like this one, the forehead flap will become the skin of the nose. So the result is this one. So it was like this and then become like this. There is, as you can see, a skin graft, but in this case, we don't have a choice. We can do as always, avoiding skin graft. You can do it if you are able to make the flap slide. In this case, it's impossible. The area is too big. So one of the well, the nose, we made the classification by perform this classification for columella. Does depend when the infection is just in the incisors, in the middles, perhaps, there is just a subcutaneous lesion. When it's stronger, then there is the base of the nose, which is harmed. And when there is a canine, the infection is much more stronger and can harm the whole columella, and sometimes get the tip of the nose until to harm even the alar cartilage and destroy completely the pyramid. So this is a quite easily technique, can be performed even for a dermatologist. So you can see the nostril is much longer from one side. So we in local anesthesia, we raise this nostril and stuck at the tip of the nose. In the next mission, we debulking it, and this is the result. So from here to here, and quite easy to perform. In this case, the hole is not so big as you can imagine. is there is a lesion of canine and incisors, always, and obviously the lateral wall of the nose. And without flap from other part of free flap from the other part of the body, just with the frontal flap, as you can see, the frontal flap with double, one to reconstruct the mucosa, another one to reconstruct the skin. So in one operation, we can reconstruct everything. And so it was like this, become like this. And as you can see, there is any skin graft. We close, we slid the flap, and in this, in the upper part, there is any skin graft. It just does heal in its own. So it's something dermatologists can follow until the end. There is any, as you can see, there is any Photoshop, anything. So when the hole is bigger, then it's not enough. The tissue from the forehead flap, well, it's not enough to reconstruct. So we need to bring, in this case, the latissimus dorsi. We pass through as a bridge under the pectoral muscle, and to fix and leave it until the next mission. And then in the next mission, we shape the palate, the orbit floor, the nose floor, and the cheek, but not the lateral wall of the nose. Everything, but not the lateral wall of the nose. Even if we got all the tissue, it's impossible to carve a lateral tissue to reconstruct the lateral wall of the nose with this flap. So we need always a forehead flap. So then the result is this one. So it's coming from here to here. The same technique for this patient. This one is a patient with HIV. And the result is this one with the same technique. So from here to here in 2 operations. So, and he's drawing himself. And this patient, 34 years old, he's spent his whole life in this situation. The infection is, as you can see, molars and canines, both canines and incisors. So a free flap, latissimus dorsi flap with 3 pallets, 1, 2, and 3 to reconstruct. And as you can see, the carotid and jugular are ready to get the flap. So the flap is here. You can see the muscle inside, and the pedicle is 10 centimeters around. So reconstruct first after the anastomosis, we reconstruct the buccal mucosa, then the orbit floor and the cheek. But as always, for the lateral wall of the nose is need other tissue. Indeed, always a frontal flap on the supratrochlear artery from the opposite side. So it was like this and become like this in one operation. In this child, we performed something quite particular. So a forehead flap, foreheads give a tissue much more thicker. But when a child like this, the skin is not as thick, and then African, they got much more elasticity in the skin. So we model like this on the temporal artery, and patient in this situation become like this, from here to here. And then the problem, there are many canker-moris, and as the poverty, the malnourished, they haven't any coin to call the ambulance or the antibiotic. And the most important problem in canker-moris is this one, is trismus. 50% of patients, they suffer trismus, the incapacity to open the mouth. The temporomandibular articulation is harmed, and there is always molar included in the infection. So what we're doing in this case is the most hard work, is to liberate all the necrotic tissue. It needs hours to liberate. And then prepare the arteries and vein, external carotid and jugular, for the anastomosis. And then she can open the mouth. But the problem is just start if without re-education, without nurse, they follow those patients with the infrastructures they got there. It's impossible to get this result. If you leave them like this, in a 5 years time, they got just 20% of this result remain. So it's the hard work for the new generation. And other pathology we perform quite a lot is cleft lip. We modify the technique. So when it's like this, so become, that is the easier. And you can see it's huge dissection, they draw in themselves, but the point is when there is a palate. When there is a palate, it's really a problem. The risk of side effect, the complication, fistulas are quite frequently. So you can perform a job like this. So reconstruct the nasal side and the palate, but then you can got anyway. You can have a fistula, and the reoperation for the fistula, well, it's quite hard. Here you got one with a fantastic palate after, but there is a fistula there. And then is for the little problem, a huge operation. He's drawing himself. And that's to remember, when we arrive, you can imagine, no emergency for burns. That's something that's incredible. In a country without emergency for burns, the skin, how can shrink the articulation, and in this case, the inferior eyelids, reconstruct with the ear cartilage and muster the flap. So, an awkward situation like this, one patient arrived with the arrow in his head, and survived, not just to that, survive even to the asportation of the arrow. It can bleed nothing, otherwise it's dead. Well, the patient like this one, in the same belt as canker-moris, the same belt as Burkitt. This is a neurosarcoma that starts in the mandibular nerve. So it's right to operate, to remove the whole tissue. We decide taking care, don't to leave any tumor just passing through 1 centimeter around. The patient live like this for 5 years. So, 14 years old in this condition, I don't know which kind of life he can live. So the 5 years he live in this condition. And then another point is anesthetic. Anesthetists, they must take care for blood, lack of oxygen, optic fever for trismus. This is the main entrance of the hospital. And at the last, I wrote a chapter about the importance to perform the operation in their own country. There are some colleagues from America, from Switzerland, they're going to fetch patient and to bring there and to keep the patient for 6 months, 1 year, and then back in a desert area without food, without electricity, living with sheep. Is really is traumatic. So the time they with us, they can make society, they make friends, they can eat properly, and it's the only way to treat. It's less painful. Other way is better. Don't go. If for the new generation, if you want to develop a dermatologic center to do whatever you want, you need to go there yourself. Other way to go to fetch a patient is really, really traumatic. So I'm finished. I just if you got some question to ask, with pleasure.
That was absolutely incredible. Thank you so much, Dr. Cataldo. Josh has now collated some questions and he'll be asking them now, if that's okay.
Okay, thank you. No, the point it was I was worried about my voice. I don't know how I cope with it. It was I can't really talk.
You did very well. Josh, are you there with the questions?
Somebody's talking, but I don't hear.
Hi, sorry, I was muted. So we have a few questions here. The first one is, how long are the breaks between missions? For example, the time between leaving the forehead flap procedures.
Well, so we went a couple of times a year. So it was in February and November. And so in the middle, so it's too hot, and then they need children's to work for the harvest, for whatever. So the time it was, so we calculate the flaps between 2 months between November and February, and or 6 months between end of February until November. 7 months. That was the time. most of the flap, they don't have any problem. You can live as long as you want. It's not a problem. It's the opposite. The vascularization is better, improved. I don't know if I.
Thank you. The second question here is, I guess I'll chronologically go with this one. How long do you wait in the first cases with active infection to perform surgery?
Well, that's depend. Well, there is not a time, a precise time. The important thing is to don't touch at the start. We need the patient to heal properly, and there is a Switzerland organization who collect the patient around in the desert area, and they feed up to prepare them for the operation. So you can wait. You're not in hurry to do whatever, you know. There is any emergency. Just the idea it was to perform 1 or 2 operations and finish. If it's going bad, 3 operations. And often we need a dermatologist in this mission to cope with the skin graft and all the diseases that are behind the dermatologic pathology.
Thank you. Another question we have here is, how many hours do these procedures take typically?
Well, you know, we are quite, we used to, we got a little experience, so we're going quite quick, and we know exactly what to do. And most of the procedures are a couple of hours, 3 hours, no more than that. But there is one 17 hours, 17. So just the whole journey is very, very hard, but it's exceptional. And it can be 7 hours, but it's too much. Usually it's between 2 and 3 hours. A cleft lift, I can do it in 45 minutes.
Okay, thank you. And we also have someone who asked, how did you get into mission work?
How?
How did you get into mission work, working with the medical missions?
Well, we work always, you know, with we are from the main hospital, University Hospital in Paris, St. Louis Hospital, and it's the Médecins du Monde who start to organize, and they call us to go as there have been some mission before. They perform many operations to reconstruct. And the idea, it was to reintroduce patient as quick as possible. And so perform a lot of microsurgery. When we get the point where we don't have the choice, we perform microsurgery. But we can try, as you saw, flap without microsurgery, even if I show you someone with microsurgery. And it was always a French organization and University of Paris.
Thank you. I think the question was more along the lines of, how did you yourself personally become involved with this kind of work, this field?
In more than 20 years. Going a couple of times a year, more than 20 years. Then you must consider the time of the study, and we perform the research to better understand the disease, which is a disease is known from 1,500, but they just knew the children, they died in a couple of weeks, but they didn't really study where the infection started and which tissues were harmed. And in this way, we can today offer the possibility for the new generation to got, you know, to know what to do, how to cope with the patients.
Thank you. And one more question here is, how can one get access for the training that's required for this surgery if they want to perform it?
Now, you know, it's quite difficult. As you know, the problem, the social problem and political problem in Central Africa is changed completely. When we arriving from the main hospital, university hospital in Paris, wide known for them, we got the hospital at our disposition. But today, everything changed. The situation between African and they want European. So it's very difficult at the time. The last I spent there, they give me a mobile to call if I've been kidnapped, as you can imagine the situation. When we started, it wasn't like this. It wasn't easy. We were facilitated because arriving with the university and everybody know us over there, does facilitate the theater room, they prepare everything for us. But then become always better, always easier. And then in the last year, well, everything it was really start to become awful. So to go there is Médecins du Monde, Médecins Sans Frontières, the international organizations, any hospital, I know, any hospital going anymore there as is too dangerous. But perhaps everything will change in the next years. And I'm thinking a good dermatologic unit can be very useful.
Okay.
Well, thank you very much, Josh, and thank you so much, Dr. Cataldo. I think we can all agree that you're absolutely inspirational and the work that you've done is incredible. This was such an amazing webinar, and it will also be available online so that more people can learn from you. So thank you so much. I'm just going to finish by sharing this final slide here. So just thank you very much for your time today. It's hugely appreciated. And everyone, thank you for attending. Please follow our Glowderm account, so Glowderm Alliance on social media, and you can learn about further upcoming events, webinars, programs, and more. We also have a mentor-mentee community as well. So thank you so much.